Hello everyone in CardioMinds channel, and welcome to the 9th video in the guidelines of acute coronary syndromes. And today we are speaking about a very common scenario to see a patient with acute coronary syndrome with comorbidities, how to deal with these situations. We are going to speak today about bleeding disorders like anemia and thrombocytopenia, chronic kidney disease, diabetes mellitus, old age and frailty, pregnancy, cancer, drug abuse, and COVID-19 infection. Let's start with the anemia and thrombocytopenia. What are the problems that anemia cause? First of all, anemia is more prevalent in elderly and frail acute coronary syndrome patients and more prevalent in those with multi-morbidities. This is an expression meaning patient with multiple comorbidities like heart failure, chronic kidney disease, diabetes, cancer, and autoimmune diseases. Each one of these comorbidities can cause anemia with a different mechanism. So presence of multiple comorbidities, of course, lead to significant anemia. And we know, of course, from the video of type 2 MI versus Minoka that severe anemia may precipitate type 2 MI, and persistent or worsening anemia in patients with acute coronary syndrome is associated with increased risk of recurrent ischemic events, death, and major bleeding. And we remember the Academic Research Consortium for High Bleeding Risk, which showed that if hemoglobin is less than 11 grams at the time of PCI, this represents a major criterion for high bleeding risk, whereas hemoglobin between 11 and 13 in males or between 11 and 12 grams in females is a minor criterion for high bleeding risk. What about the treatment of anemia in those patients? So far, there is no established strategy for treating anemia in those patients. The need for blood transfusion, as we remember from the video of complications of acute coronary syndrome, is associated with a 4-fold increase in early mortality and 3-fold increase in death or MI in acute coronary syndrome patient. This may be related that those patients needing blood transfusion are already in severe anemia, and this represents a sign for increasing mortality, or those patients, the blood transfusion itself represent a hazard for the patient because it induces a pro-inflammatory state. So blood transfusion may increase mortality by itself. We have two strategies for blood transfusion, which are liberal blood transfusion, in which it is done if hemoglobin is less than 9 grams, or restrictive blood transfusion, in which the hemoglobin, if less than 7 grams, we transfuse blood. We had multiple comparisons between liberal and restrictive blood transfusion strategies in the CRUSADE initiative study and the reality trial, which may prefer restrictive blood transfusion to reduce the hazards caused by blood transfusion. So based on the inconsistent study results and lack of adequately powered randomized controlled trials in case of acute coronary syndrome, restrictive policy for blood transfusion is preferred in anemic patients, and no specific recommendation so far regarding the cutoff point in hemoglobin or hematocrit for blood transfusion. What about thrombocytopenia? Also, it is more prevalent in elderly and frail patients, and the clinically relevant thrombocytopenia can be defined as platelet count less than 100,000 or a drop in platelet count more than or equal 50% from the baseline. Thrombocytopenia itself increases the risk of death, major bleeding events, and life-threatening thrombotic events, and it makes sense. Presence of thrombocytopenia, of course, increases the risk for bleeding disorder, either minor or major bleeding, and presence of thrombocytopenia may make you withhold the antithrombotics needed for acute coronary syndrome, so increase the risk for thrombotic events. The Academic Research Consortium for High Bleeding Risk defined a platelet count less than 100,000 to be a major criterion for high bleeding risk. We have two famous types of thrombocytopenia that we are going to speak about in brief. First one, during or following glycoprotein 2B3A inhibitor like tirofiban or eptifibatide. It is mostly an idiosyncratic reaction caused by the drug itself, and so in those patients who are having glycoprotein 2B3A inhibitor infusion, platelet count should be assessed 8 or 12 hours after the starting of infusion, at the time of any bleeding complication, and then again after 24 hours. Remember, sometimes thrombocytopenia may be due to platelet aggregates inside the sample itself, and if you repeat the count again, it is normal. So before assuming that there is a thrombocytopenia caused by the drug, repeat the sample to exclude platelet aggregates. The first measure to stop the infusion if there is clinically relevant thrombocytopenia or any bleeding occurs, even if minor, in order to prevent progression of thrombocytopenia. Platelet transfusions may be needed if there is active bleeding with profound thrombocytopenia with a platelet count less than 20,000, but sometimes it may be ineffective due to the reversibly binding drug present in the circulation for 2 hours after stopping the infusion. That's why it may be more effective after more than 2 hours from stopping the infusion. Sometimes we may need fresh frozen plasma or cryoprecipitate in patients with ongoing major bleeding. But remember, the problem here is in the platelet count, not in the coagulation factors, but sometimes if the bleeding is severe and ongoing, we may need fresh frozen plasma, and rarely we need IV immunoglobulins or corticosteroids in refractory cases, but mostly we are not going to need them. Don't forget that patients who experience thrombocytopenia while on glycoprotein 2B3A inhibitor should avoid subsequent exposure to this drug again, because they are liable to thrombocytopenia again if they start the infusion. Another famous type is the heparin-induced thrombocytopenia, famously known as HET. It has 2 types. Type 1, which is a benign type, it is non-immune mediated, just mild thrombocytopenia presenting within 48 to 72 hours of the onset of unfractionated heparin, and it usually resolves without complications despite continued use of unfractionated heparin. Type 2 is the dangerous type, which is immune mediated and is potentially fatal. It may cause prosthrombotic complication, not only bleeding complications. It occurs in 0.5 to 3% of those receiving unfractionated heparin, low molecular weight heparin, or other heparin products. It should be suspected when the count drops to less than 100,000 per milliliter, but it does not usually drop to less than 20,000, and it usually occurs within 5 to 10 days after the first exposure, or sometimes within hours if the patient has previously received heparin products. What should you do if you suspect HET? You should stop all types of exposure to heparin, including medications, heparinized flush, and coated catheters, not only the medication. You should pay attention to any products that may contain heparin, and start prophylaxis with antithrombotics that are non-heparin anticoagulants like argatropan, danaproid, or lipiridine. Sometimes we may use fondaparinux or bivaridine as alternatives, although they are not specifically approved for HET, but sometimes they are the only available anticoagulation. And platelet transfusions, of course, are not recommended in HET. They are not beneficial, and sometimes they may increase the immune-mediated destruction of the platelets. Bivaridine is the recommended alternative to unfractionated heparin for patients presenting with acute coronary syndrome who have a history of HET, because you cannot use again unfractionated heparin or low molecular weight heparin in those patients. However, in absence of heparin-dependent antibodies, re-exposure does not necessarily cause a relapse of HET if there is evidence of presence of heparin-dependent antibodies at the first time that the patient developed HET, so he has a potential for relapse of HET if he had re-exposure to any heparin products. Now let's move to a famous comorbidity, very common to be seen, which is chronic kidney disease. Moderate to severe CKD is present in more than 30% of acute coronary syndrome patients. This is a high percentage, indicating that CKD is very common in acute coronary syndrome. The problem is that patients with acute coronary syndrome and CKD receive less interventional therapy because some cardiologists are reluctant to perform coronary angiography for those patients fearing contrast nephropathy, and less pharmacological treatment because some cardiologists without evidence may omit some medications, doubting that they are eliminated by the kidney. So the big problem is that patients with CKD have worse prognosis than patients with normal kidney function due to higher risk of thrombotic complications and bleeding complications as well. The good news that data from observational and registry-based studies indicate that acute coronary syndrome patients with moderate to severe CKD have a better prognosis with early revascularization than with medical treatment alone. But there is no evidence from randomized controlled trials so far. So, revascularization in those patients can enhance the prognosis and reduce the risk of thrombotic complications. This is an interesting table showing all antithrombotics regarding the renal elimination, whether they need dose adjustment or not, and whether they are contraindicated if the creatinine clearance is less than 30 or less than 15 milliliter per minute. So the recommendation in the guidelines that the use of low or isoosmolar contrast media at the lowest possible volume is recommended as a class 1 for invasive strategy in patients with CKD, and is recommended to assess the kidney function in all acute coronary syndrome patients using the estimated GFR. Don't depend on the serum creatinine alone. We should assess the GFR based on the age, body weight, and the sex. And it is recommended to apply the same diagnostic and therapeutic strategies regarding the indications for primary PCI, for early invasive or emergency invasive strategies in patients with CKD, paying attention to dose adjustment for the antithrombotic medications as in patients with normal kidney function. Don't omit the chance for coronary revascularization, basing your assumption that this patient has CKD, so we should avoid coronary revascularization. This is completely wrong. You should discuss the benefits and risk with the patient and then reach a decision. And class 2A, to adopt good hydration during and after angiography in those at risk of contrast nephropathy, especially those with acute kidney injury or CKD with GFR less than 30 milliliter per minute. The evidence around the choice of hydration regarding normal saline versus ringer, timing and duration of treatment is so far conflicting, but of course you should start good hydration during and after angiography because it minimizes the risk of contrast nephropathy. Now, a famous comorbidity, or can be considered a risk factor rather than a comorbidity, which is diabetes mellitus. The problems that acute coronary syndrome patients with diabetes more commonly present with non-specific symptoms like angina equivalent, resulting in delay in post-diagnosis and treatment. They tend to have more advanced coronary artery disease at diagnosis, usually multi-vessel coronary artery disease. They have worse long-term prognosis, especially in those requiring insulin treatment in comparison to those requiring oral hypoglycemics and in comparison to non-diabetic patients. And acute coronary syndrome itself may result in temporary hyperglycemia due to catecholamine-induced stress. So the diagnosis of diabetes should be made during hospitalization, but not on one test of random blood glucose. We should repeat it like sliding chart and assess the hemoglobin A1C. Better also to perform fasting and 2-hour postprandial blood glucose. Therefore, glucose lowering in those patients is important to prevent microvascular complications and also to prevent the progression of atherosclerosis in the large epicardial coronaries. However, recent trial evidence shows that the reduction in the risk of new acute coronary events, heart failure and renal impairment, is independent of the baseline hemoglobin A1C when you use these medications like SGLT2 inhibitor or the sodium glucose transport 2 inhibitor and the glucagon-like peptide receptor agonist, because they have independent reduction for the risk of coronary events, heart failure and renal impairment. And so you should reduce blood glucose but try to avoid the risk of hypoglycemia, because when using intensive insulin therapy, the patient is prone to hypoglycemia, which may increase the risk of coronary events. So avoid hyperglycemia, but also avoid hypoglycemia. So the recommendation is the guidelines that you should base the choice of long-term glucose lowering treatment on the presence of comorbidities, including heart failure, CKD, and obesity, but the preference is for the SGLT2 inhibitor and GLP receptor agonist. And you should assess the glycemic status for all patients with acute coronary syndrome, regardless they give you a history of diabetes or not. Assess the random blood glucose, hemoglobin A1C, and better also to assess fasting and 2-hour postprandial blood glucose. And it is recommended to frequently monitor blood glucose in those with known diabetes or hyperglycemia, like blood glucose more than 200 mg per deciliter in order to avoid hyperglycemia and reduce blood glucose, but without causing hypoglycemia. And don't forget that glucose-lowering treatment is indicated in those with persistent hyperglycemia, but with avoidance of hypoglycemia. And just reminding you that we have the 2023 ESC Guidelines for management of cardiovascular disease in patients with diabetes. We are going to dedicate some specific video to discuss these guidelines. Now moving to a famous dilemma in dealing with acute coronary syndrome patients, which is the old age and frailty. Old age is one of the major predictors of adverse outcomes following acute coronary syndrome. And the problem is that those more than or equal 75 years are often excluded or underrepresented in the clinical trials, with limited data on the optimal management of old patients with acute coronary syndrome. And the problem is that old age is usually associated with frailty, that we are going to speak about shortly, multimorbidity, and a higher risk for post-ischemic events and bleeding events in acute coronary syndrome. That's a big problem, of course. High sensitivity cardiac troponin assay have an excellent diagnostic performance in old patients, but the only problem is that the specificity is lower than in younger patients because there are a lot of non-cardiac conditions that may result in elevated cardiac troponin. That's why you need to follow up the troponin and exclude non-cardiac conditions that may result in troponin elevation. So in the absence of robust clinical trial evidence, the decision regarding how to manage old patients with acute coronary syndrome should be individualized based on multiple factors like ischemic versus bleeding risk, estimated life expectancy for this patient, presence or absence of comorbidities like anemia, CKD, need for any future non-cardiac surgery, and the quality of life, frailty, cognitive and functional impairment. Don't forget the patient preference, because you should respect the patient's desire and the estimated risk and benefits of this invasive procedure. In case of an old patient presenting with STEMI, primary PCI still has improved outcomes for all age. However, the data are limited in the very old cohort, like those more than 80 years, with lack of formal assessment of frailty or comorbidity. And also in the absence of strong data, primary PCI should be considered for all patients with STEMI, regardless the age. And if it cannot be performed in a timely manner, fibrinolytic may be reasonable, although of course it carries a high bleeding risk. And in case of cardiogenic shock and cardiac arrest, age is an independent predictor of mortality following PCI. This results in worse prognosis in case of STEMI or non-STEMI with cardiogenic shock or survival of cardiac arrest if the patient has old age. What do we mean by frailty? Frailty is different from old age. It is a syndrome characterized by reduced biological reserve leading to failure of homeostatic mechanisms following stressor events like acute coronary syndrome. So far, there is a lack of consensus on the optimal tool to assess frailty in old patients with cardiovascular disease. So remember, frailty does not mean that this patient is old. Sometimes you may see a patient more than 80 years, but he is not frail. And sometimes you see a patient in his 50s, but he is frail due to presence of multimorbidities and reduced functional capacity. The problem is that frail patients with non-ST elevation acute coronary syndrome less frequently receive adequate pharmacotherapies for acute coronary syndrome, less frequently receive invasive assessment for coronary revascularization, have more complex coronary artery disease, very common to have multivessel affection, longer duration of hospital stay due to multimorbidity and non-cardiac conditions, at higher risk, of course, of mortality, higher risk for composite all-cause mortality, MI and stroke, and higher rate of unplanned revascularization that may result in major bleeding and poor health-related quality of life. So in all patients with non-ST elevation acute coronary syndrome referred for coronary angiography, the presence of multimorbidity, which of course makes the patient frail, is associated with increased risk of long-term adverse cardiovascular events with increased risk of all-cause mortality. So what should we do? Those patients should have routine assessment of frailty, for example, using the Rockwood frailty score, and assessment of comorbidity like the Charlson index during acute coronary syndrome. And according to the results, if those frail patients have a high risk for future cardiovascular events and low risk of procedural complications, offer medical treatment plus an invasive strategy for coronary revascularization. But if the patient has a low risk for future cardiovascular events and a high risk for procedure complications, offer medical treatment alone without invasive strategy if these treatments are futile due to the extensive frailty, so palliative end-of-life care approach should be considered. So the recommendations and guidelines regarding the old age and frailty. It is recommended to apply the same diagnostic and treatment strategies in older patients as in younger patients due to absence of robust clinical trial evidence, and it is recommended to adapt the choice and the dosage of antithrombotic medications based on the renal function, co-medications that the patient is taking, comorbidities, frailty, cognitive function, and specific contraindications if present. And for frail old patients with comorbidity, a holistic comprehensive approach is recommended to individualize interventional and pharmacological treatment after evaluations risk versus benefit. Now let's speak about a famous problem that is facing us in many acute coronary syndrome patients, which is cancer. The four most common types of cancer in patients with acute coronary syndrome are lung cancer, which represents the highest mortality and highest risk of major adverse cardiac and cerebrovascular events, colon cancer that represents a problem in the bleeding risk, and then prostate cancer and breast cancer that have relatively fewer complications. The problem is that cancer and coronary artery disease share several risk factors like old age, smoking, obesity, diabetes, hypertension, dyslipidemia, and physical inactivity. But patients with a history of cancer should be treated like other acute coronary syndrome patients having no cancer. But the management of acute coronary syndrome with active cancer has some issues related to the ischemic versus bleeding risk that should be taken into consideration. Patients with active cancer and acute coronary syndrome tend to be older, with a larger number of comorbidities with more extensive coronary artery disease, often having concomitant hematological and coagulation abnormalities, increasing the risk for bleeding disorder or thrombotic complications. And observation studies have reported that acute coronary syndrome in patients with cancer is associated with increased risk for major cardiovascular events, bleeding, cardiac and non-cardiac mortality. In case of using the Academic Research Consortium for High Bleeding Risk, the patients with active cancer diagnosed in the past 12 months are considered at high bleeding risk, and so we should assess the balance between ischemic and bleeding risk in those patients on an individual basis. So the recommendations in the guidelines that the invasive strategy is recommended in cancer patients presenting with high risk acute coronary syndrome with expected survival more than or equal 6 months. Retrospective data reported that the lower use of invasive management in cancer patients with STEMI worsens the prognosis because there are better outcomes in those patients who undergo invasive management. That's why in STEMI, primary PCI is still the preferred approach even if the patient is having cancer. When the coronary anatomy is not amenable for PCI, so we should resort to CABG surgery, but after a multidisciplinary team discussion, if the cancer prognosis expects the life expectancy to more than 12 months, so we should undergo CABG. The preferred P2Y12 inhibitor for acute coronary syndrome patients with active cancer is clopidogrel. Due to the high bleeding risk in those patients, especially those with cancer colon, so prasugrel and ticagrelor are not preferred. Also, they have potential drug-drug interaction with the cancer therapy due to the interaction via the cytochrome P450. That's why clopidogrel is preferred. And so you should liaison in a team with an oncologist and clinical pharmacist to decide about the drug interaction, whether to use this drug or not. Sometimes we may need to have a temporary interruption of cancer therapy if we suspect that it is a contributing cause of acute coronary syndrome, because we have a lot of anti-cancer therapies that may induce ischemia and acute coronary syndrome, which may occur in more than 10%. Of course, you cannot remember all these anti-cancer therapies in your mind. That's why you should have a team with an oncologist in order to discuss whether this medication may be the cause for the acute coronary syndrome or not. This is an interesting table explaining the different mechanism by which the anti-cancer therapy may result in acute coronary syndrome up to acute MI. For example, accelerated atherosclerosis and plaque rupture that may be caused by the gonadotropin-releasing hormones or the radiation therapy, coronary vasospasms that may be caused by fluoropyrimidines or vinca alkaloid or vascular endothelial growth factor inhibitors, and coronary thrombosis that may be caused by alkylating agent like cisplatin, cyclophosphamide, or platinum chemotherapy or proteasome inhibitors. That's why the MDT discussion with the oncologist is essential to decide whether this medication is a cause or not. In case of temporary interruption, we should start alternative anti-cancer therapies decided by the oncologist and the cardiologist that are not associated with MI. They should be considered after revascularization if indicated and after the patient is stabilized on medical treatment without complications. Conservative non-invasive strategy should be considered as a class 2A if the patient has poor cancer prognosis with expected survival less than 6 months or very high bleeding risk. This is related to the advanced cancer stage, for example, metastatic cancer or severe irreversible non-cardiovascular comorbidities. The invasive management in those with metastatic cancer or life expectancy less than 6 months has shown no mortality benefit compared with conservative approach. That's why conservative treatment should be considered in those patients. And the big no in cancer patient regarding the platelet count. Don't use aspirin if the platelet count is less than 10,000. Don't use clopidogrel if the count is less than 30,000. And don't use prasugrel or ticagrelor if the count is less than 50,000. Remember that these recommendations are for the thrombocytopenia in case of cancer patients, not in acute coronary syndrome in general. I know, of course, that many of you may use these cutoff points regarding thrombocytopenia in an acute coronary syndrome patient, but remember, these recommendations are based on clinical trials in cancer patients with acute coronary syndrome. Now moving to a physiological condition rather than being a comorbidity that may occur with acute coronary syndrome. Needless to say that acute MI in pregnancy is associated with poor maternal and fetal outcome with a mortality rate twice as high as in cases of MI occurring during the peripartum period. So there is nothing called that MI in pregnancy. Do not touch the patient and do not undergo coronary angiography because this patient is pregnant and we have a risk of radiation exposure to the fetus. No, the mortality rate here is high. And we should use the same diagnostic criteria for acute coronary syndrome in pregnant and in non-pregnant patients. Pregnant women with STEMI should be managed the same as non-pregnant females. So if the patient has a STEMI and she is pregnant, she should have STEMI with precautions regarding the radiation exposure, but do not omit the chance for coronary revascularization because here you are exposing the mother and the fetus to high mortality. So primary PCI is still the preferred reperfusion therapy due to high mortality associated with STEMI in pregnancy. We should put this idea in mind. We have different pathologies that may lead to MI during pregnancy. First of all, the incidence of MI is higher in multigravidas in comparison to primary gravidas, and especially during the third trimester. Spontaneous coronary artery dissection is the most common cause of MI in pregnancy, mainly in the late pregnancy or early postpartum period, and we have discussed this pathology in the video of technical aspects of invasive strategy. Usually it needs conservative treatment because usually spontaneous healing occurs unless there is flow limiting dissection causing ongoing ischemia or hemodynamic instability, or there is isolated left main dissection. In this case, PCI is indicated. Coronary thrombosis is not uncommon during pregnancy, either due to atherosclerosis, especially if the pregnant female is having multiple risk factors for atherosclerosis, or pregnancy occurring in older age, like for example pregnancy more than 40-year-old, or thrombophilia that may expose the patient to risk of coronary thrombosis and MI. Sometimes coronary vasospasm may occur during pregnancy due to increased vascular reactivity to angiotensin II and noradrenaline, or increased activation of renin, angiotensin, aldosterone system due to decreased uterine perfusion in the supine position, or use of ergot alkaloid to control antepartum or postpartum hemorrhage. It may precipitate coronary vasospasm. So in this case, the patient may need DHP calcium channel blockers or nitrates to relieve this coronary vasospasm. So the management plan for pregnant females with acute coronary syndrome should be determined by a multidisciplinary team consisting of cardiologist, obstetrician, anesthesiologist, neonatologist, and it should be treated in an ICU providing maternal monitoring and obstetric care, not an ordinary ICU. And acute coronary syndrome treatment should not be delayed for delivery. Start the pharmacotherapy and the invasive therapy if indicated as soon as possible. Do not wait till delivery, and sometimes delivery should be postponed for at least 2 weeks post-acute coronary syndrome due to increased risk of maternal mortality during this time. Regarding the radiation protocol, try to avoid radiation during the first trimester because this is a period of organogenesis, and so there is a high teratogenic risk to the fetus. The recommended radiation exposure to the unshielded abdomen is 1.5 milligray, as in this case less than 20% reaches the fetus, and so if it is a shielded abdomen, the radiation exposure to the fetus is lower, and procedures should follow as low as reasonably achievable radiation dose principle. For example, reduce the frame rate, try to reduce the radiation and the fluoroscopy time as much as we can, try to use other modalities like the IVUS or OCT in case if there is any doubt regarding the coronary pathology to reduce the dependence on radiation, and of course shield the abdomen from below and above to reduce the radiation exposure to the fetus. Remember, iodinated contrast material has not been reported to cause any teratogenic effect, so you can use contrast in a pregnant female, and low-dose aspirin is safe, but clopidogrel should only be used when essential. For example, you perform a coronary angiography and you decided that this patient is needing PCI. In this case, you should use clopidogrel, but avoid preloading without knowing the coronary anatomy and use it for the shortest duration. Prasugrel and ticagrelor so far are contraindicated during pregnancy because there is no evidence of safety. Another famous problem that we may face with acute coronary syndrome, which is drug abuse. Drug use in society is more prevalent in younger adults. That's why acute coronary syndrome occurring in an individual under the influence of psychotropic drug is more common in younger individuals. The problems that patients who have presented with acute coronary syndrome associated with alcohol or illicit drug use have an increased likelihood of rehospitalization and adverse prognosis in the longer term. Why does drug abuse represent a problem? It may have a direct cardiovascular effect caused by a toxic substance, or sometimes it is just the natural history of acute coronary syndrome in an individual with risk factors for atherosclerosis who at the time of acute coronary syndrome is under the influence of alcohol or illicit drugs. So by chance the patient was under effect of these drugs while he presents with acute coronary syndrome. The complicating drug effects may manifest in the nature of the presentation of the acute coronary syndrome or on the behavior of the patient. For example, the patient is non-compliant with the invasive procedure, the patient is refusing, the patient is agitated, or the patient has disturbed conscious level during the invasive procedure. First of all, regarding alcohol dependence. Alcohol toxicity, as we know, may occur in both the acute form or the chronic form, which is famously called alcoholism. The alcohol may result in cardiodepressant effect causing hypotension that may precipitate myocardial ischemia, arrhythmias, famously the atrial fibrillation, which is partially due to the associated electrolyte disturbance or the direct effect of alcohol. Non-cardiac problems may complicate acute coronary syndrome like subarachnoid hemorrhage, pancreatitis, trauma, or infection. And don't forget that chronic alcoholism can result in liver cirrhosis, which may increase the bleeding risk, especially upper GI bleeding due to esophageal varices. So if you are giving this patient antithrombotics, you will increase the risk for upper GI bleeding. What is the problem with the illicit drug use? We have the CNS stimulants that increase the patient alertness and euphoria. For example, amphetamines, cocaine, methylene dioxymethamphetamine, famously called ecstasy. They have sympathomimetic effect, either direct or indirect, by increasing catecholamine release in the synaptic cleft, resulting in positive chronotropic and vasopressor effects. This may result in systemic hypertension and tachycardia, increasing the shearing stress on the coronary plaque, so increasing risk of plaque rupture and atherothrombosis causing type 1 MI. And also it may result in coronary vasospasm due to the increased catecholamine release, or severe tachycardia causing supply-demand mismatch, resulting in type 2 MI. So there are two mechanisms for infarction in those patients. The use of cocaine represents a higher risk, as in a contemporary hospital registry with data from 2001 to 2015, 6.8% of acute coronary syndrome patients under the age of 50 years presented with acute coronary syndrome associated with cocaine consumption. The problem that patients using cocaine compared with those without cocaine, if they are having acute coronary syndrome, they carry a higher incidence of in-hospital ventricular tachycardia or risk of VF due to increased catecholamine release and sympathetic stimulation, and higher risk of recurrent MI and cardiovascular deaths during follow-up of up to 5 years. What about the CNS depressants that may result in confusion or delirium? Benzodiazepines, codeine, and opiates have direct effect on the respiratory center, resulting in disturbed conscious level with pinpoint pupils that may occur with morphine poisoning or heroin overdose, and they may result in predyspnea and CO2 narcosis. Cannabis, like hashish and marijuana, is associated with increased risk of cardiovascular hospitalization, especially tachyarrhythmia, and to a lesser extent acute MI or coronary vasospasm. So don't neglect that this patient is taking cannabis, because this patient is prone to tachyarrhythmia and infarction. So what to do for those patients? First of all, they should identify and target specific risk factors that may result in atherosclerosis. For example, cigarette smoking. Most of the drug addicts are smoking cigarettes, so you should tackle these risk factors. Social support should be provided and rehabilitation for those individuals to treat drug addiction and try to minimize the chance of relapse, besides the cardiac rehabilitation to support compliance with secondary prevention protocols, and clinical audit for the social and cardiac rehabilitation should be provided. And the last comorbidity to speak about today is the nightmare in 2020 resulting in the pandemic, COVID-19 infection. The problem is that cardiovascular comorbidities are common in those patients with COVID-19, and the presence of cardiovascular disease itself is associated with severe COVID infection and higher mortality. That's why it is important to focus on the cardiac history for those patients. Cardiac manifestations in those patients are associated with worse outcome. Sometimes the patient may have acute cardiac injury with raised troponin level appearing several days after the start of fever. This suggests myocardial damage associated with the viral infection. COVID-19 itself is associated with increased risk of thrombosis. That's why those patients are prone to acute coronary syndrome, even MI, even if it is the first time for them to suffer from cardiac complications. COVID-19 may result in cardiac affection by different mechanisms. It may be secondary to a direct effect of the virus on the myocardium, effect of hypoxia resulting in supply-demand mismatch and type 2 MI, or myocarditis may occur in the context of systemic immune response caused by the COVID-19 infection, which was famously called cytokine storm. In a patient hospitalized with COVID-19 and you noticed mild elevation in the cardiac troponin, it may be the result of a pre-existing cardiac disease representing chronic myocardial injury or acute myocardial injury related to COVID-19. So in this case, you should have serial follow-up of troponin to differentiate between acute and chronic myocardial injury, and if there is evidence of acute injury, search for evidence of ischemia to diagnose or exclude acute MI. So what about the treatment? The same principles that we applied in all comorbidities. COVID-19 should not change the management plan for those patients with acute coronary syndrome. Primary PCI is still the treatment of choice for STEMI patients and COVID-19. Do not omit this chance and try to take the protection measures for all the team. In the cath lab, fibrinolysis is indicated if the patient presents in the first 12 hours of MI and he will not be able to perform PCI within 120 minutes of STEMI diagnosis. And don't forget that cardiac patients should have appropriate vaccination against COVID-19. The same principles that we apply in the annual influenza vaccine to reduce the risk of COVID infection, which may be hazardous in those patients per se. So we have reached the end of our video today, and our take-home message that screening for the common comorbidities like diabetes, anemia and CKD is essential for all acute coronary syndrome patients. And do not forget the multidisciplinary team discussion, which is essential for most comorbidities to assess the benefit-risk ratio and so formulate an appropriate treatment plan. We applied the MDT discussion today for cancer, pregnancy. Also, we can apply it for chronic kidney disease, for anemia, thrombocytopenia, to reach a management plan appropriate for this patient. Thank you very much for watching this video, and next week we are having the last video in the guidelines of acute coronary syndrome.